the outlines of my presentation will include metabolic pathway, then the pathophysiology of metabolic disorders, and then the classification of metabolic disorders, then the related history and physical finding suggestive of metabolic diseases, and then the proper investigation to reach the diagnosis of metabolic disorders, and finally, I will talk about the proper treatment. Now, the metabolic pathways. I need to tell you that and highlight on the fact that the cells are consistently carrying out thousands of chemical reactions which needed to keep the cells and the whole body alive and healthy. These chemical pathways and reactions are often linked together in a chains or pathway. All of those chemical reactions take place inside the cells, collectively called metabolic pathways. And the metabolic pathways are divided into the catabolic pathways and anabolic pathways. And during the metabolic pathways, the enzymes play an important role to facilitate the process by serving as a catalyst in order to facilitate conversion of one chemical molecule to another chemical molecule. Now, what is the catabolism? The catabolism is a set of metabolic pathways in which that there will be release of energy by breaking down of bigger molecule into a smaller molecule. As you can see here, this is a big molecule which through a catabolic pathway, there's a breakdown of this big molecule to produce an energy. While the anabolism, which is the opposite of the catabolism, is a set of metabolic pathway in which that there will be a production of a bigger molecules from a smaller unit, and usually this reaction requires an energy. Now, the inborn error of metabolisms. Inborn error of metabolism are those disorders characterized by a block at any point in the normal metabolic pathway. Usually, the block in the metabolic pathway could be due to a deficiency of enzyme, a receptor where the enzyme can bind, a transport vehicle, membrane bomb, and structural elements. It's important to know that those proteins are constructed by what is called DNA, which provides an instruction for building up those proteins. So, in a case of any point mutation affecting the DNA, definitely the production of those proteins gonna be affected, and at the end there will be disruption in the metabolic pathway leading to inborn error of metabolism. Now, this is an example of the metabolic pathway destruction. Usually we have a precursor or molecule A which should be converted to substrate B through an enzyme AB, for example. Then there should be production of more helpful molecule which can be called end product or molecule C through an enzyme BC, for example. If there is inborn error of metabolism, there might be a block of VC enzyme. So what will be the result? As a result, there will be an activation of abnormal metabolic pathway. So the substrate B will not be able to produce end product C, and as a result, there will be production of a toxic metabolite D. And by this, there will be production of some signs and symptoms and abnormalities in the metabolic pathway. Now, why it is important to diagnose the metabolic disorders? Till now, the number of metabolic disorders is exceeding 700, which is a huge number. Those disorders are considered very rare disorder, but collectively, they account for a significant proportion of neonatal and childhood morbidity and mortality. The diagnosis of those disorders is not only important for treatment, but also it's important to provide a proper genetic counseling for the family. Now, how can we classify metabolic disorders? Metabolic disorders can be classified into those disorders in which that there will be problems with the production of energy, and those disorders can present with a metabolic crisis. Those disorders can be called also small molecule disorders, in which that there will be abnormalities in metabolic pathways affecting, for example, carbohydrate, amino acid, organic acid, or even fatty acid. The next classification of the next category of metabolic disorder is the disorder in which that there will be problems with the breaking down or production of certain molecules in the organelles. And those disorders can be called also disorders affecting organelles, like, for example, the lysosomal disorder, mitochondrial disorder, peroxisomal, and disorders of glycosylation. Now, when shall we think about metabolic disorder? Metabolic disorder requires high index of suspicion, depending on history, the physical examination, and also investigation. Now, any baby presenting with severe illness or he's sick enough to do investigation, including blood culture and LV, but those investigations were negative, we have to think immediately about metabolic disorders. Family history, it provides also an important clues regarding metabolic disorders. A consanguinity is a hint letting us to think about metabolic disorder, because a lot of metabolic disorders are inherited as autosomal recessive. So consanguinity increases the risk of autosomal recessive disorder. A presence of unexplained neonatal death or fetal losses can lead us to think about metabolic disorder. If there is a family history linked just to the mother, we need also to think about the X-linked disorders in which the males are exclusively affected, and also we need to think about the mitochondrial disorder in which that the mitochondrial DNA is maternally inherited. A positive family history of metabolic disorder can be also helpful, but as I told you, metabolic disorders are very rare, so a negative family history is not always reassuring. Another clue in the history is the timing of the signs and symptoms. For example, if the baby was doing very well, but after introduction of a certain type of diet, he started to have symptoms, we need to think about metabolic disorder, especially if there is a block in the, for example, carbohydrate or a protein metabolism. Moreover, response to therapies. If the patient is very sick and we are providing him with antibiotics, but there is no response to usual therapies, we need to think also about metabolic disorders in which that there is accumulation of toxic metabolites. Now, what are the findings in physical examination that help us to think about metabolic disorder? Definitely in physical examination, we need to look generally to the child if there is any dysmorphic features or if there is any abnormal odor of the body secretion. ENT examination, head and neck, they give us a hint regarding metabolic disorder, like the presence of cataract, retinitis pigmentosa, glaucoma, or also a squint. CNS examination is also very important to be not forgotten during the examination, because abnormalities in tone, resistant seizures to medication with the presence of tense fontanelle will lead us also to think about metabolic disorders. A lot of metabolic disorders can be presented with metabolic acidosis, and as the result, the body will try to compensate for this metabolic acidosis through respiratory alkalosis. So those patients may present with deep acidotic breathing called chiasmal breathing, and also tachypnea, because hyperammonemia is one of the features of metabolic disorder, and hyperammonemia is considered a stimulus for the breathing center in the brain. So this may explain why those patients may present with unexplained tachypnea and chiasmal breathing. Patients who are suffering also from metabolic disorders can present with the myocardial dysfunction and also with arrhythmia. abdominal distension due to hepatosplenomegaly is also another clue regarding the metabolic disorder, together with the presence of jaundice. Here are some specific features indicating specific metabolic disorders. Coarse facial features can be found in lysosomal storage disorders due to accumulation of the toxic metabolites in the variable facial tissue. Cataract is a common finding in untreated conditions of galactosemia and also can be found in Zellweger disorder. Retinitis pigmentosa is also a common finding in mitochondrial disorders, while cherry red spot can be found in lysosomal disorders, especially in lipidosis and Tay-Sachs disease. Hepatosplenomegaly, especially if the liver is very firm, we need to think about storage disorders like, for example, glycogen storage disorder and also sometimes of urea cycle diseases. Hydronephrosis and renal cysts can be found in Zellweger syndrome. Biotinidase enzyme deficiency can be presented with eczema and alopecia, while Menkes disease can present with abnormal kinky hair, and we can find the patients may present with albinism and decreased skin pigmentation and phenylketonuria. I told you before that metabolic disorders can present with abnormal odor of body secretions. Why? Toxic metabolites can accumulate in the body and can produce very bad or specific odor. Like, for example, in glutaric aciduria and isovaleric acidemia, the patient's urine the smell is similar to the sweetie feet and also to the acrid. While in maple syrup urine disease, the urine smell is similar to the maple syrup. Phenylketonuria, the patient's urine smell is similar to the mousy or musty odor, while in tyrosine boiled cabbage is a common smell for the body secretion. Now, the investigation. What is in the investigation that led us to think about metabolic disorder? Definitely, the patient is having metabolic acidosis with an increase in anion gap, because in metabolic disorder, as I told you, there will be accumulation of toxic metabolites. Those toxic metabolites can be, for example, an organic acid, and the increased production of acids can result in metabolic acidosis with increased anion gap. Respiratory alkalosis is another feature suggestive of metabolic disorder, especially in hyperammonemia. Low blood urea relative to creatinine, because in urea cycle defect, there will be abnormalities or defect in synthesis of urea, but the synthesis of creatinine is not affected. Hypoglycemia is very important clue toward the metabolic disorder, especially if there is non-ketotic hypoglycemia, in which the body is not able to produce ketone bodies, and also in a case of hepatomegaly. Now, what are the clinical presentation of metabolic disorder? There are three types of the clinical presentations, which are the silent disorders, acute metabolic crisis, or progressive neurological deterioration. Silent disorder. Those disorders usually do not present with a life-threatening crisis, and they can be easily missed during neonatal period because they are silent. But as long as those disorders are not treated, the patient will present with progressive brain damage and developmental disabilities later on in life. Like, for example, phenylketonuria. I need to tell you that a story of one family. This family was having a child with developmental delay and also with hyperactivity. So this patient was diagnosed with ADHD. Then later on, this family has another child, and this family has moved on to United Arab Emirates, where newborn screening has been established. And the other newborn discovered to have phenylketonuria. So that's a child who has been diagnosed with ADHD, has been also tested for phenylketonuria, and discovered that this patient is also having phenylketonuria, but unfortunately it was a late diagnosis. Different treatment has been started for both of those children. The first one was started late, So there was very minimal improvement in her condition, but the second child, the treatment had been started from a neonatal period, and now the child is doing very well. So this is an example of one of the silent metabolic disorder. The second type is the disorder that present with acute metabolic crisis, and usually those disorders can present in infancy with the life-threatening events. The patient usually presents with severe illness and he's very sick, though the investigation usually does not give us a hint regarding the cause. So whenever that the patient is presented with a life-threatening event without a clue in the investigation, definitely we need to think about metabolic disorder. And usually those children are protected in utero by the maternal circulation, which provide a missing product to remove toxic metabolites. Example for acute metabolic crisis disorders are urea cycle defect, like for example OTC and citrullinemia, and also organic acidemia like methylmalonic and isovaleric acidemia. The third type is the disorders that can present with a progressive and neurological deterioration, like for example, the organelle disorder, like Tay-Sachs disease, Gaucher, and metachromatic leukodystrophy, in which the patient will be born with a normal physical examination and with the negative signs and symptoms, but as there is accumulation of toxic metabolites in the brain, the patient, due to non-functional enzyme, the patient will present with a progressive loss of the motor and cognitive activity. And later on, the patient will have early death during the adolescence. Now, what are investigations? Whenever we are thinking about metabolic disorder, immediately we have to do metabolic investigation as soon as possible. Why it is important to do that? The outcome of a treatment of many metabolic disorder is directly associated with the rapidity with which problems are detected and also treated. Now, the investigation can be divided into first line and the second line investigation. I mean by first line investigations I mean that by the first line investigations are the investigations which are present in most of the hospitals and can be done in any labs. Those investigations are the CBC, because some metabolic disorders, especially organic acidemia, bone marrow suppression is a common feature. Acid-base balance and electrolyte is very important to detect any metabolic acidosis, blood glucose to detect any hypoglycemia, plasma ammonia, which can be very high in urea cycle defect and also can be moderately high in some disorders like, for example, organic acidemia and fatty acid oxidation disorder. The lactic acid is also very important to be done because it can give us a hint regarding the mitochondrial disorder and also fatty acid oxidation disorder. Liver function test, urine ketones, and also urine reducing substance, which may indicate the presence of abnormal reducing substance and metabolite in the urine. Serum uric acid is also an important clue regarding the metabolic disorder because it can be very low in some disorder like molybdenum cofactor or can be high in some purine pyrimidine disorders. Now, I told you that ammonia is very important to be investigated in any case suspected metabolic disorder. Now, if we did ammonia and we found that the ammonia level is high, what shall we do? We have immediately to do the blood gases to look for the bicarb and CO2. If the blood gases are normal in the presence of high ammonia with no ketones, we need to think about urea cycle disorder. But if there was acidosis, in the absence of ketosis, we need to think about fatty acid oxidation disorder. But if there is acidosis with ketosis, we need to think about organic acidemia or mitochondrial disorder. While if the plasma ammonia is normal, we need still to think about metabolic disorder. Normal plasma ammonia does not exclude metabolic disorder. So if the ammonia is normal and the blood gases is also normal, we need to think about the silent disorders, like for example, phenylketonuria, and also some organelle disorder, like for example, peroxisomal and lysosomal disorder. Here, just repetition of what I have mentioned. Normal plasma ammonia with no acidosis, we need to think about phenylketonuria and organelle disorder. While high plasma ammonia with no acidosis, no ketosis, we need to think immediately about urea cycle defect. In a case of normal or high plasma ammonia in the presence of acidosis or ketosis, mitochondrial and organic acidemia should be suspected, while in the presence of acidosis and high ammonia with no ketosis, definitely we need to think about fatty acid oxidation disorder. This slide is just explaining the urea cycle defect in which that there will be very high ammonia with abnormal metabolite, like for example, citrulline. Now, if the patient is having hypoglycemia, and this is very common presentation of a patient suffering from metabolic disorder, what shall we do? Immediately, we have to do urine reducing substance to look for non-glucose reducing substance, like for example, the fructose and galactose. If the galactose is present in the urine as a reducing substance, definitely we have to think about galactosemia. While if hypoglycemia is not associated with urine reducing substance, but there is a ketone bodies in the urine, definitely we need to think about disorders affecting the gluconeogenesis, like for example, glycogen stored gluconeogenesis, and disorders also affect the glycogen metabolism, like glycogen stored disease and organic acidemia. While non-ketotic hypoglycemia will indicate fatty acid oxidation disorder or hyperinsulinism. So it's important to know that non-ketotic hypoglycemia is an indication of just two disorders, which are fatty acid oxidation disorder or even hyperinsulinism. Now, the second line investigations, which are not present in all hospitals, usually those investigations present in metabolic centers, and those investigations are considered confirmatory tests. What are those investigations? Gas chromatography mass spectrometry, which is called GCMS. It's important to diagnose abnormal toxic metabolites in urine, like in organic acidemia. Plasma amino acid and acylcarnitine profile can be detected through tandem MS, which is important for diagnosis of urea cycle, organic acidemia, amino acidopathies, and also fatty acid oxidation disorder. HPLC or high performance liquid chromatography is important for quantitative analysis of amino acid in plasma and in urine, which is important for diagnosis of organic acidemia and also amino acidopathies. Lactate pyruvate ratio is important in a case of high lactate, which will give us a hint toward diagnosis of mitochondrial disorder. Urinary uric acid can be high in some cases of hyperammonemia and urea cycle defect. Now, the enzyme assay. As I told you, in metabolic disorder, there will be a block in some point of metabolic pathway, which can be due to deficiency of certain enzyme. So, to do enzyme assay is another second-line investigation, but unfortunately is not available for most of inborn error of metabolism. What are the available enzyme assay? We are having the biotinidase enzyme assay, which is important to diagnose the biotinidase enzyme deficiency, which can be presented as interactable seizure, alopecia, and developmental delay. Galactose 1-phosphate uridyl transferase assay, which is important for diagnosis of galactosemia. Now, a neuroimaging study is very important tool for diagnosis of metabolic disorder, as a lot of metabolic disorder can have certain CNS manifestation. For example, cervical disorder can present with abnormal cortical migration and sulcation, while agenesis of corpus callosum can be present in mitochondrial disorder. In maple syrup urine disease, There will be edema of the cerebellum and also of the brainstem. In organic acidemia, the patient may present with abnormal changes of the basal ganglia, while in glutaric aciduria, the patient may have, for example, frontotemporal atrophy and subdural hematoma. MRS is also very important to detect abnormal waves in the brain, like for example, very high lactate peak can be present in mitochondrial disorder. EEG is also very important in diagnosis of certain metabolic disorders which are resistant to anti-epileptic medication, like for example, complex rhythm in Mabel Ceram-Burden disease. Prolonged chain fatty acids is also another important investigation, which usually high in peroxisomal disorder. And now definitely the mutation analysis is available widely in most of the labs, and it can definitely provide a definitive diagnosis to metabolic disorder, because metabolic disorder usually caused by a single gene mutation analysis. CSF amino acid analysis is also very important for diagnosis of certain amino acids in which that there will be abnormal metabolites in the CSF. Now, the management. It's important to start management as soon as possible, even without a definitive diagnosis, because as I told you, the prognosis of those disorders is directly linked to the time of initial treatment of the treatment initiation. Now, what's the aim of the treatment? In the treatment, we aim to reduce the formation of toxic metabolites by decreasing the substrate availability. For example, if the metabolic disorder is a result of a block in the amino acid metabolism of organic acid, we can, for example, restrict the protein. So by this way, we will reduce the production of toxic metabolites. We also would like to provide adequate calories in order to maintain an anabolism and to reduce the catabolism. We need also to enhance the excretion of toxic metabolites, like for example the dialysis, which is the modality of choice and the treatment of significant hyperammonemia. Cofactor therapy can be also helpful in the treatment of in the treatment of a specific metabolic disorder to enhance a metabolic pathway. We need also to provide supportive measurement, like for example, in the case of seizure, we need to avoid certain anti-epileptic medication. Like in hyperammonemia, sodium valproate should be avoided because it worsens the ammonia level. We need also to maintain normoglycemia, normothermia, fluid electrolyte balance, and also we need to treat the precipitating factor, like for example, an infection. In the case of respiratory depression or severe respiratory alkalosis, we can support the ventilation through the mechanical ventilation. Now, I will discuss the management of the very important and serious metabolic crisis, like for example, the hyperammonemia. We know that the origin of ammonia is from the amino acid, which is a protein. So if the patient presents with hyperammonemia, we need to stop all types of proteins, and at the same time, we need to provide adequate calories through the intravenous glucose and lipid to enhance anabolism. If the patient has significant hyperammonemia above 500, we can do the dialysis to enhance excretion of ammonia, or we can use a medication that activates an alternative pathway, like for example, sodium benzoate, sodium phenylbutyrate, arginine, and carnitine. Another metabolic disorder, which is very serious and we need to provide an immediate management, is the organic acidemia. Again, we know that organic acid's origin is from protein. So if the patient presents with metabolic crisis and he's having organic acidemia, definitely he will present with severe acidosis, with hyperammonemia, and he will be very sick. So we need also to convert the catabolic state to anabolic state by keeping the patient MPO and stopping all sources of protein. We need to provide the patient with adequate glucose through D10 1.5 maintenance. We need also to maintain good hydration and to provide the treatment for the seizure Carnitine is also very important treatment modality for cases of organic acidemia because carnitine usually binds to the organic acid and facilitates excretion of the organic acid through the renal system. Treating acidosis through the sodium bicarb or citrate together with vitamin B12, which can be helpful in some metabolic disorder. This is the end of my presentation.